Good afternoon, Radcliffe Cardiology. I'm Mirvat Alasnag. I'm an interventional cardiologist based in Jeddah, Saudi Arabia. With me today is Dr. Connie Hess. She's an interventional cardiologist and an associate professor of medicine in the University of Colorado School of Medicine, United States. We're going to discuss the sub-analysis that was presented at the TCT conference this year on the VOYAGER PAD study. Now, the initial trial was a double-blind, placebo-controlled trial of patients with peripheral vascular disease who underwent lower extremity revascularization, and they were randomized to rivaroxaban 2.5 milligrams twice a day or placebo on a background of aspirin 100 milligrams daily. Clopidogrel was administered per operator discretion. About a total of 6,564 patients were enrolled, with 3,286 in the rivaroxaban arm and 3,278 in the placebo arm. The median follow-up was about 28 months. Now, that trial demonstrated that rivaroxaban at a dose of 2.5 milligrams plus aspirin was associated with a significantly lower incidence of the composite outcome of acute limb ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, or death from cardiovascular causes than aspirin alone. Now, with respect to the sub-analysis here this time around, Dr. Connie, can you review with us the design and the results of your analysis?
Yes, absolutely. So this, as you mentioned, was a secondary analysis from VOYAGER PAD. We focused on the subgroup of patients who underwent endovascular qualifying revascularization for the trial. And there were two objectives for this analysis. The first was to assess whether there was an association between paclitaxel drug-coated device use and all-cause mortality, which was the primary outcome for this analysis. The second objective was to assess for whether there was consistency in the effect of rivaroxaban plus aspirin versus aspirin alone on the VOYAGER primary endpoint, as you described earlier, regardless of drug-coated device use. Now, because drug-coated device use was not randomized in VOYAGER, we did use a statistical method called inverse probability treatment weighting to account for differences in the groups, in the drug-coated versus non-drug-coated groups. And so, there were approximately 4,300 patients in VOYAGER that underwent endovascular revascularization, and about a third of them were treated with the drug-coated device. Now, in the adjusted or weighted analysis, we found no association of mortality with drug-coated device use. In fact, the hazard ratio was 0.95 and the confidence interval was 0.83 with an upper bound of 1.09. We further demonstrated that there was no heterogeneity in effect of rivaroxaban, so a consistent 10 to 15% benefit with rivaroxaban versus placebo in reducing the VOYAGER primary endpoint, regardless of drug-coated device use.
So as you're well aware, previously there was significant controversy on the use of the drug-coated devices after the publication of a meta-analysis by Dr. Katsanos and his group in December 2018 in the Journal of the American Heart Association. The authors then reported an increased long-term mortality compared with non-drug-coated devices. This led to warnings from regulatory agencies about the use of the drug-coated devices. The large sample size, long-term follow-up, and adjudicated outcomes of your analysis are actually encouraging. So how do you think the results of your analysis will impact the use of drug-coated devices in the future?
Yeah, that's a great question. And I think it's important to understand the background and the context of this analysis first. Just to kind of set the scene. So, patients with peripheral artery disease, as you know, are difficult to treat and have been very challenging from an interventional perspective because of poor patency after the procedure and need for repeat interventions. And so, when drug-coated devices first came on the scene, everyone was very excited because they reduced restenosis and improved patency. And so initial uptake of this technology was quite rapid. In fact, it almost became the standard of care in many places. And so when publication of this analysis came out showing an association between long-term mortality and paclitaxel, I think it was quite a shock to the community, for multiple reasons. First, obviously, it's a very serious outcome we're talking about. Second, there was a very potentially large population of patients at risk. And then third, there wasn't really a clear mechanism that we could understand by which paclitaxel would be associated with mortality years down the line, kind of long after the drug has left the system. And so, these data really had a profound impact on the field. As you mentioned, regulatory agencies such as the U.S. Food and Drug Administration issued a letter to healthcare providers saying, we should restrict use of these devices. And so in response to these data, there's been a huge flurry of activity, sort of a firestorm really in the community, with multiple investigators trying to understand whether the signal is real. There have been a lot of prior reports published on the issue, and there have been some mixed results, with some showing the increase in mortality associated with drug and some not showing this. Now, important to understand is that many of these prior analyses had some significant limitations. So for example, the observational analyses, although large in population, were non-randomized and they did not have adjudicated outcomes. In terms of the analyses of randomized data, a lot of these analyses had missing data. There was short-term follow-up, missing important baseline characteristics, et cetera. And so I think the question has really been unanswered. And in that context, I think a lot of people have been eagerly anticipating the results of this analysis, mainly because the Voyager data, as you mentioned, do address many of these limitations, right? It was a large sample size. We had long-term follow-up. There was actually 99.6% ascertainment of vital status in this group. So really, we knew vital status for almost all the patients in this analysis. And so, I think many in the community will find our results reassuring. I think many of them will actually want to start using drug-coated devices again for the potential limb benefits. Now, of course, we have to see what the FDA thinks. I think many are hoping that they'll loosen their stance on restricted use of these devices. And I will also note that I think whenever we offer a treatment to patients, we do have to have an honest discussion of the risks and benefits of these treatments. And so to that end, we actually have a second analysis of drug-coated device use, this time looking at limb outcomes from Voyager that we'll be presenting at the VIVA conference coming up in November. And I think, our hope is that these data will also help to inform the question of potential risk and benefit when we talk to our patients about these devices.
So it's very impressive follow-up in your trial. But looking at the results, the weighted and unweighted results of your analysis were slightly different. In the unweighted analysis, there was a lower mortality observed in patients receiving the drug-coated versus non-drug-coated devices. However, no difference, whether benefit or risk, was noted in the unweighted results. Could you just elaborate a little bit on that?
Absolutely, that's a great observation. And as you pointed out, in the unweighted analysis, we did actually observe lower mortality in the group of patients that were treated with the drug-coated device versus not. And so I think the first important take home here is that it was lower mortality, right? So we didn't see an excess of mortality, which is sort of the question at hand here. And the second observation is that this just shows us that these populations are different, right? Again, use of drug-coated device was not the randomized variable here in Voyager. And so it shows you that there is some provider selection bias in which patients are getting treated with drug-coated devices. Now, when we looked at the baseline characteristics for these populations, we did see some significant differences. For example, patients in the drug-coated device group were younger. They were more often treated for claudication versus critical limb ischemia. They had greater use of baseline medications such as statins and clopidogrel. And so I think it's really these differences in baseline characteristics that then account for the lower mortality that we observed in the unadjusted analysis.
So confounders, including risk factors and comorbidities, types of adjunctive revascularization therapies, the location of the disease, and so on, don't appear to impact the final results, though. Is that correct?
Yes, absolutely. All of those things that you listed, I think, as I kind of alluded to, there were differences between the drug-coated device group and the non. However, we used this methodology of inverse propensity treatment weighting, which actually was quite robust. We had two different statistical teams involved in this analysis. The first was actually blinded to outcome, and they were responsible for determining the propensity score and then kind of the variables included in the models. The second team then incorporated these models and ran the final analyses. And so this was a very robust process that accounted for all of these differences. When you looked at the standardized differences, pre versus post weighting, you can see that there were some significant differences before, and then afterwards, those were essentially resolved and not present anymore. And so I do feel confident that these baseline potential confounders were successfully adjusted for in our analyses.
You know, just looking at the baseline characteristics, and I'm just honing in on this a little bit more, the number of women that were enrolled and chronic kidney disease were relatively low. So we're talking about 20-25%, as opposed to smokers, for example, who are close to 80%, and diabetic patients 40-50%. So across the board, do you think these results can be applied to women, for example, or those with advanced kidney disease and so on?
Yeah, so that's another good question. I think there's always this issue of generalizability of results from clinical trials to the kind of quote unquote real world population. I think if you look at the baseline characteristics of Voyager, they are actually quite similar to many of the real world analyses, the observational analyses that we've looked at. For example, I've done some work in the Premier Healthcare database looking at hundreds of thousands of patients undergoing peripheral revascularization, and these numbers are really not so far off. In fact, Eric Sisemski has actually looked at the Medicare database, and the baseline characteristics of the population here that we looked at in the subgroup are actually very similar to what he looked at in the Medicare population. Now, they were obviously a little bit older, but in general, I do think that there is consistency. And so I think that these results are overall applicable to some of the other sort of more real world populations, if you will.
So since Voyager PAD was focused on antiplatelet and antithrombotic therapy, clopidogrel use, as I mentioned earlier, with the discretion of the operator, do you believe in any way it could have contaminated the results of your analysis?
We actually had the same concern initially, because there was, the patients who end up getting treated with drug-coated devices had significantly greater use of baseline clopidogrel. And as you said, this is, again, up to the operator. It's, we allowed it for up to 6 months in the trial, but I don't think actually that it had an effect or a potential contamination of our results, again, because we had such a robust statistical, process of adjusting for these confounders. And when you look actually in the sort of post-weighting group, the standardized difference is almost zero. So, we really, to the extent that we could, tried to adjust for any potential known confounder. And I think we were actually quite successful.
I agree with you, absolutely. Well, I know in the United States, you still do not use drug-coated devices for coronaries. However, in the rest of the world, there are a lot of areas or a lot of regions where it is available to operators, and it has been used for coronary interventions. So do you think the results of your analysis can be extended to the coronary drug-coated technology?
Yeah, that's a very interesting question. I think really it's funny. There really hasn't been the same controversy in the coronary circulation. If you look in particular here, the concern is with paclitaxel specifically, right? So if you look at the coronary paclitaxel literature, with the exception of maybe one analysis, it's all been very consistent that there's no association between mortality and paclitaxel use. And, I say this also because once the peripheral data came out, everyone started saying, okay, well, if there's a real association between this drug and mortality, I mean, it should be evident in other vascular beds, right? So people have looked at the coronary vasculature, people have looked at use of these devices in AV fistulas, for example, and there really has not been any signal. So, for whatever reason, the issue is specific to use of the drug-coated device in the periphery. And so I think it's really kind of been a non-issue in the other vascular beds.
I really am impressed with this study, the design, and the statistical analysis that the team put through. But I think it is important to ask at this conjuncture, particularly with the long-term follow-up of your analysis, do you think it puts an end to the controversy, or do you believe we still need a dedicated randomized trial to put this to bed?
Yeah, and that actually I think is the question of the day, right? Everyone's kind of saying like, have we closed the door? I think from a purist standpoint, from a true kind of trialist perspective, we need a randomized trial, right, to really definitively answer the question. That would require an adequately powered trial for mortality. And so the problem, as everyone knows, I think, is that would require thousands of patients. And, there's really no appetite for anyone to really fund such an undertaking. And so I think we're not going to get it. That's sort of the purist, but also the practical answer. I think, in that context, our data probably are the most definitive to date, of the currently available data. And so I do think it helps to close the door on the question. That being said, I think it's extremely important moving forward that we conduct device trials better though, right? I think, for example, there are actually a lot of ongoing and upcoming trials of drug-coated device use in the periphery. And so there's some important lessons I think that as a community we should have learned from here. And I think that's that for device trials in this space, we need to minimize patient loss to follow-up. We need to minimize patient withdrawal of consent. We need to, to the extent possible, have complete ascertainment of vital status at the end of the study. I think that moving forward, those efforts will not only help to, kind of confirm our findings here today from the Voyager analysis, but also will help us, make sure that device trials are conducted better and will help with potential adverse event discovery so that we avoid, being in the same situation again.
Thank you very much. This was a very engaging conversation here. Well, thank you, Radcliffe Cardiology, and we'll see you again in another episode.
Thank you.